It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal hepatobiliary surgery, and it's a pleasure to be here today.
I'm Pritesh Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
70-year-old female with history of borderline resectable T3N0 pancreatic adenocarcinoma who has completed 12 cycles of FOLFIRINOX with stable disease. So she originally presented with epigastric discomfort, new onset diabetes, and elevated lipase. Her performance status is 1. She also has a history of obesity and type 2 diabetes. She denies any history of tobacco, alcohol use, or illicit drug use. And her family history is non-contributory. In June, she had a CT scan of the abdomen and pelvis, which was negative for lung metastasis, and had fullness in the pancreas uncinate with main duct dilatation, distal pancreatic atrophy, and acute pancreatitis. She subsequently underwent an upper endoscopy within the US, and it was noted that she had a 2.1 by 1.9 centimeter hypoirregular mass of the uncinate process with obstruction of the main pancreatic duct, and the mass appeared to involve the portal vein and abut the SMA. And additionally, there was a 1 centimeter portal hepatis lymph node. No other lymph nodes were noted, and the biopsy is consistent with adenocarcinoma. So Dr. Siegel, please explain what these images are now showing from August and then again in February.
Okay, so the two upper images are non-contrast and either early portal venous phase or even arterial phase, and then we have one image a little lower. And you can see that there is an irregular tumor involving the SMA and the SMV and some irregularity in the region of the uncinate process. And that's really about it that we can determine on these images here.
Okay. And then what would you say in regards to after she's completed her 12 cycles, do you see any dramatic differences?
Well, I don't know which ones are, if we're going to say the bottom one is a post.
I believe so.
Then it does look a little bit better in the region of the celiac and the SMA. You can see on the upper image there's a little bit too much tissue and irregularity just to the right of the SMA and the SMV. And on the corresponding image on the lower image, it's much better.
Thank you so much. So how would we approach the management of this patient moving forward? So we have a woman that's completed her 12 cycles of FOLFIRINOX, seems to have tolerated it extremely well, and maybe some benefit based upon her most recent CT scan. So I'm going to turn it first towards Dr. Kubi, and then I would also like to hear actually Dr. Patel, because I know there's a lot of controversy now since there's been some updates regarding the Alliance protocol. So I'll leave it to either of you at this time. Dr. Kubi?
Yeah, thank you, Dr. Ng. So this is an interesting case. I don't see any evidence of biliary obstruction having been discussed either in the history or in the imaging. And it's because it's a low uncinate tumor, which are notoriously challenging tumors surgically to deal with. The interface, 180 degrees with the SMA, raises the biggest concern. So with venous involvement only, we might consider going to the operating room with a response to the chemotherapy without radiation, and there's variability on that. But when you do have a 180-degree interface with the SMA, then you're concerned that you're not going to get total clearance of the tumor, even when you dissect along the SMA. So certainly in our tumor board, we would lean on Dr. Patel to discuss giving some radiation before proceeding to the operating room.
Dr. Patel, can you give us your opinion regarding the role of radiation in this setting for this lovely woman?
Yes, thanks, Dr. Eng. As you mentioned, I think certainly a controversial topic right now. The study that you reference has been, there was an alliance trial 021501, which is a FOLFIRINOX plus or minus SBRT randomized study in the borderline pancreatic cancer setting. We have only an abstract presented thus far, but it appears to show that SBRT was associated actually with a worse negative margin resection rate, numerically at least, and possibly worse numerical survival as well. So SBRT really is a small field of irradiation. As Dr. Siegel sort of alluded to in this case, the confines of the tumor, the borders of the tumor are actually usually difficult to determine. And that of course, translates directly to radiation oncologists delineating where this tumor starts and stops, particularly with a very small area of irradiation. So with SBRT, I think it's in particular, it's a little tricky because the target is often hard to define. On the flip side, a little wider margin is something that's often done when we use chemoradiation. In general, we fractionate the radiation in this case, so as opposed to a 1 or 2 week treatment, now the fractionated radiation takes 5 or 6 weeks. We feel this is safer for the luminal GI structures. And in this case, an uncinate process tumor is particularly challenging because this tumor abuts the duodenum. And it's going to remain in close proximity to the duodenum throughout the entire breathing cycle. So inspiration and expiration, you're not going to get the tumor separating from the duodenum. They're touching each other. And so with all of that in mind, in a situation like this, I usually do not recommend SBRT and typically recommend chemoradiation in order to give the best dose we can give at the tumor luminal GI interface and not have to compromise. And at the same time, to make sure that we're putting enough radiation in all the areas where we know there's a risk for positive margin in the future along the retroperitoneal margin, and to cover the elective lymph node areas, which are often not covered with SBRT. So when there's close proximity to a luminal GI organ, like in an uncinate process tumor, we rarely use SBRT at our institution, and most often are giving 5-FU-based chemoradiation.
Thank you for watching. Since this interview, new information has been released. And now we go to the update.
There have been multiple clinical trials demonstrating the lack of benefit to the addition of radiation for patients with locally advanced unresectable pancreatic cancer. And yet we keep doing these studies over and over again. Fiat Cao et al. Added to this to the presentation of the CONCO 007 trial. In this trial, patients with strictly defined locally advanced pancreatic cancer were randomized to receive chemotherapy with FOLFIRINOX or gemcitabine based on the physician's choice. Treatment was given for 3 months, and those who had not progressed were then randomized to continuation of the same chemotherapy regimen versus continuing with gemcitabine and radiation therapy concurrently. Initially, the primary endpoint of the study was overall survival, but because there weren't enough events that had occurred, that 800-something patient study was reduced to about a 336 patient study, with the primary endpoint now being R0 resection, which one could argue is not necessarily a validated primary endpoint. Nevertheless, about 60 patients in each arm went on to have surgery, which was necessary to determine the primary endpoint. While the PathCR and R0 resection rate were higher in the chemoradiation arm, the median progression-free survival, the median overall survival, and the 5-year overall survival rate were actually no different with radiation therapy. And this is consistent with what has been seen with the LAP-07 studies and several other studies, that there is no clear benefit to survival to the addition of radiation therapy for locally advanced unresectable pancreatic cancer. The struggle is that we do see in practice and in studies that adding radiation improves that path CR rate, and thus presumably may increase the cure rate for those who are able to undergo resection. But how do you choose those patients? How do you know who's going to benefit the most? So there are going to be trials that are still going to be done, but we just need to be more careful and more intelligent about how we put these patients through these studies. And using radiation for locally advanced pancreatic cancer as a blanket across the board approach is really not warranted. We at our institution review every patient after each scan to make a group decision, a tumor board decision, as to whether we should or should not pursue radiation therapy.